Now, metabolic surgery, on the contrary, is not focused on diseased organs, but on putatively, and I say putatively because we don't know what mischief these organs are really doing, but putatively normal organs like the intestine, performing their homeostatic contributions in order to induce them to do something else and favorably alter the body's neurohormonal milieu. Slide, please. Now I can discuss 22 metabolic surgery procedures that have been done over the years. I'm not going to do that. Next slide. I'm just going to make a few past remarks. In the 1880s to the 1960s, we seem to have had a pandemic of ulcer disease, particularly duodenal ulcer disease. And we did gastrectomies and vagotomies, normal vagus nerves, normal stomachs, but the duodenal ulcer that we never touched went away. So that's metabolic surgery. And this was way before Heliobacter. In 1889, there was a suggestion for doing oophorectomies for breast cancer metastases. And I'll get back to this. In 1923, we started to do sympathectomies for hypertension. When I started in residency, we used to do back incisions and take out the sympathetic nerves along the renal pedicles, and that lowered idiopathic hypertension blood levels. Slide, please. So I'm going to give 4 progenitor examples. The partial ileal bypass for hyperlipidemia and therapy for atherosclerosis, which is the #1 cause of death in the United States. Oophorectomy, which was hormonal therapy for cancer, the #2 cause of death in the United States. And our metabolic bariatric surgery for type 2 diabetes, of which there are 35 million people in the United States, about 10% of the US population, and metabolic bariatric surgery for obesity per se, and the mitigation of obesity comorbidities. And it is said, I hope that's wrong, that the US incidence of obesity is estimated to be 40% in 2050. I just read something today that obesity has gone from 41% to 40% in a big celebration. Well, it's at least going in the right direction. Next slide, please. So let's start with the partial ileal bypass. I started this in my laboratory in 1962 in animals, particularly the rabbit. It's bypassing the distal 200 centimeters of ileum and anastomosing it to the cecum. Next slide. Now, some of the highlights of the work that we did from the 1962 to 1970s, we showed that cholesterol and bile acids, which are the end products of cholesterol metabolism, are primarily absorbed and reabsorbed in the intrahepatic cycle in the ileum. So that was sort of a textbook contribution to where things are absorbed. Now, the intrahepatic cycle is very efficient. 90% of your bile acids you use over and over. 60% of cholesterol is reabsorbed. So in essence, you use the same bile acids for breakfast, lunch, and dinner. And we showed that the partial ileal bypass that I just showed you lowered cholesterol in hypercholesterolemic animals made so by diet. And then we did something very interesting. We made the rabbits atherosclerotic, and they had, by feeding them cholesterol, and they had coronary lesions. And by giving a transient cardiac arrest, putting a catheter into their aortic roots, and making an injection, we could do coronary arteriograms on rabbits. And we showed that before being treated with partial ileal bypass, 3 months thereafter, their atherosclerotic lesions mitigated, disappeared, or at least got smaller. And in 1963, I did the first human partial ileal bypass operation. Next slide. So let's look at the history, basic history, epidemiology of atherosclerotic cardiovascular events. It's been associated with high cholesterol levels in populations. 99% of babies that are born have a cholesterol lower than 100. Now, in my parents' day, normal cholesterol was said to be 260. That's a long way from 100. The 1% of babies that are born with the cholesterol over 100, they are doomed to be familial hypercholesterolemics. And then there were various reports of people climbing mountains in the Andes and so on, who have low cholesterols, don't have atherosclerosis. So therapy was initiated. The most effective therapy probably was the Mediterranean diet, advocated by Keyes and Blackburn from my institution, University of Minnesota, and Stamler in Chicago. Actually, Jerry Stamler just recently died, and he got his last grant when he was 102 years old. Wonderful man. And then came early drugs. Nicotinic acid, which had tremendous amount of side effects, couldn't be used too often. And MER29, which was actually toxic. It caused severe renal failure and other problems. Next slide. So there was a search for statistical proof of the lipid atherosclerosis hypothesis, namely that if you lower cholesterol, it mitigates atherosclerosis. Now, there were 13 diet or drug trials, including 3 funded by the NIH, all with negative or marginal results. None achieved what we have as the magical standard of a p-value less than 0.05 significance. And then we started to do a trial, a $65 million trial in the mid-70s involving the partial ileal bypass. The first study ever to use metabolic surgery in a major trial. And this was the program on the surgical control of the hyperlipidemias, or POSH. Started in 1973, formally ended in 1990, but we followed these patients well into almost the present time. Now, this study gave the first statistically significant proof of the lipid atherosclerosis hypothesis. Next slide, please. What was the protocol? 838 patients, male and female, single ECG documented MI. So this was a secondary trial. Ages 30 to 64, with a total plasma cholesterol of at least 220, or a LDL cholesterol of at least 140. That's after a low cholesterol, low fat diet for at least 6 weeks. They were randomized in 4 different centers, geographically distributed. The controls 417, and the controls were on diet, and partial ileal bypass still with diet 421. Slide, please. We did metabolic studies in the POSH trial. Cholesterol absorption went down 60%. Fecal steroid excretion went up 380%. And those are the neutral sterols, cholesterol, and bile acids. The body reacted. Cholesterol synthesis went up, turnover went up, but the cholesterol pools went down. And there are 2 cholesterol pools in broad terms: the freely miscible, which is the liver and the plasma, and the less freely miscible, which includes the arteries. And we showed by isotope analysis studies that the actual cholesterol content of atherosclerotic arteries decreased. Next slide, please. Here, this shows the reduction in LDL cholesterol in the surgery group, about 40%, with both groups still on diet. Next slide. When we first presented our results at the American College of Surgeons in San Francisco, they gave us a whole half day, which was wonderful. And then we published the results in the New England Journal of Medicine. We showed that the primary endpoint, and this is 1990, of atherosclerotic coronary mortality and non-fatal MI was reduced 35%, highly significant. Non-fatal MI reduced 40%, highly significant. The incidence or the need for CABG or PTCA, 60% lower, significant. For those individuals with an ejection fraction over 50, overall mortality reduced 36%. We didn't quite achieve the 0.05 level with total ACHD mortality or overall mortality. Next slide, please. So we waited. And 21 years later, yes, indeed, we had a p-value less than 0.05, showing that survival was increased, overall mortality was decreased. Next slide. And this was a very unusual study. I'm not sure it could be done today. We did coronary arteriograms on all these patients who survived each interval at 0, 3, 5, 7, and 10 years. And we showed a lack of progression in the surgery group. Next slide. And most interestingly, when we had enough patients, we showed an actual regression, just like in the rapids, of atherosclerotic coronary lesions at 5 and 7 years by the marked cholesterol lowering, the metabolic surgery of partial ileal bypass. Slide, please. So, as I said, in 1990, we gave our primary results, and they preceded the statin trials by 2 years. So we were the first, surgery was the first to show that lowering cholesterol mitigated atherosclerosis. So in conclusion, POSH, the first NIH-funded metabolic surgery trial, utilizing the partial ileal bypass as the intervention modality, was the first randomized controlled trial to prove the lipid atherosclerosis hypothesis and was therefore the progenitor of global lipid intervention and reduction in the incidence and prevalence of the sequelae of atherosclerotic cardiovascular disease. Heart attacks are going down worldwide, and strokes are going down worldwide. And one of the main causes is that cholesterol levels are going down worldwide. May I have next slide, please? Slide, please. Now let's go on to the second progenitor, oophorectomy. In 1889, Alfred Schinzinger in Germany suggested that if you did a bilateral oophorectomy, it would cause remission of breast cancer metastases. Now, this was years before Starling and Bayliss in England in 1962 defined hormones and their actions. And interestingly, Schinzinger never performed a bilateral oophorectomy. But 1895, 6 years later, George T. Beatson in Scotland, I don't know if he ever knew about Schinzinger, but he performed 2 bilateral oophorectomies for metastatic breast cancer with excellent remissions. And he became known as the father of endocrine ablation and cancer management. Slide, please. 1974, tamoxifen essentially replaced oophorectomy. And today, this idea of tumor hormonal denial therapy is achieved pharmaceutically for breast, prostate, thyroid, adrenal, neuroendocrine, pituitary, uterus, and other malignancies. So, this idea of Schinzinger so long ago, of Baton's work 6 years later, was the progenitor of using hormonal denial pharmaceutical cancer therapy. Next slide. Now let's turn to type 2 diabetes. That's got a long history. 3,000 years ago, in the so-called Ebers Papyrus, there is a definition, well, not a definition, it's a description of diabetes as honey urine, that people in ancient Egypt who had a sweet tasting urine, I don't know why they tasted the urine, was described as honey urine. Now, in the 2nd century AD, a gentleman known through history as Aretius of Cappadocia wrote a perfect description of diabetes and named it diabetes. 1921, Banting and Best, Canada, isolated insulin from dog pancreas. 1970, Eli Lilly's biosynthesized insulin. 1922, Werner Bell in Ireland described metmorphin and introduced in the United States in 1995. Now, as has been stated by Bill, metabolic surgery or obesity, submetabolic surgery was initiated in 1953 by Richard Varco in our institution here at Minnesota. In 1985, Walter Porres wrote his classic paper showing that type 2 diabetes disappeared within days of a gastric bypass. Had nothing to do with weight loss. And I'll show you that slide. And after 1985, there have been thousands of peer-reviewed confirmatory papers for gastric bypass and other bariatric procedures that this metabolic operation mitigates type 2 diabetes. Next slide. And this comes from the original Porres paper, and I think he drew it himself. You know, he's a cartoonist. And it shows that 2 days after a gastric bypass, there's a marked reduction in glucose levels, insulin levels. Certainly, it's not due to weight loss. There's a metabolic effect. Next slide. So let's look at what came out of this knowledge. It was the knowledge of GLP-1. Now, GLP-1 was first described in 1950. 1983, it was shown to be secreted by the L cells of the small intestine. In 1992, John Eng of England isolated GLP-1 from the venom of Gila monsters. I found this out first from Ed Mason, the originator of bariatric surgery, who was at Minnesota and then went to Iowa. And what made them look at Gila monsters and extract the venom, I have no idea. But they had pure GLP-1. In 2017, Novo Nordisk introduced GLP-1 as their drug Ozempic. So GLP-1 actions, what is it? It stimulates insulin and glucagon secretion and inhibits food intake and gastric emptying. Now, how did people know about this? And how did finally the pharmaceutical houses catch on and make GLP-1? Because of the information, the knowledge that came out of metabolic bariatric surgery. Slide, please. So it was a progenitor, our surgery. 2012, first of many reports by many bariatric surgery investigators of markedly increased GLP-1 after bariatric surgery. And that drew attention to it. And from 2017 onward, there's a proliferation of these drugs on the market. Today, it's a billion-dollar industry of putting GLP-1 and analogs on the market. I guess the one that's best known, they're all the drug semaglutide is what it's called, GLP-1, but the drug on the market is Ozempic. When I run on the treadmill, there's continuous ads for all these drugs with these fancy new names, and Ozempic is one of the leading ones. Next slide. So in conclusion, with respect to the progenitor status of type 2 diabetes, prior to metabolic surgery, medical therapy for type 2 diabetes provided palliation at best for the ravages of this disease, cardiovascular events, strokes, limb loss, blindness, kidney failure, neuropathy, and a diminished life expectancy. Metabolic surgery instead of palliation provided for some a cure or long-term remission of type 2 diabetes with an increase in life expectancy. So metabolic surgery was the progenitor of GLP-1 pharmaceutical therapy of today for obesity. I mean, for diabetes, that's a misspelling, for diabetes. And there's an interesting sidelight here. The SOS, the Swedish obesity surgery study, seemed to show that after 10 years or so, maybe diabetes recurred in some of these patients. And they said, well, therefore the surgery is no good. Not the SOS study, but a lot of other investigators or people just said that. Well, if you can postpone the ravages of type 2 diabetes for 10 years or 15, 20 years, you have gained a lot. I mean, nobody would make such a foolish statement by saying, well, this drug caused a delay in a cancer for 10 years, so it's no good. If you can do that with diabetes, you already achieved something. But about 50-60% are permanently cured, let's say cured, from their diabetes with metabolic bariatric surgery. Next slide. And now let's get to obesity. Very ancient operation. It appears in the Bible. There's descriptions. It's been around for a long time. It's become a world pandemic and in and of itself a progenitor of leading causes of death, not good things, but death. Atherosclerotic disease, strokes, diabetes, hypertension, other diseases. Therapy, as you all know, multitudes of dietary, drug, exercise, and lifestyle changes have failed, really, and are expensive. 1953, bariatric surgery, Richard Varco, was introduced and succeeded. And in 2021 came Wegovy. And you know what Wegovy is? It's twice the concentration of semaglutide in the diabetes drugs. It's the same thing. It's GLP-1. And so now by taking Ozempic and doubling the dose, you now have Wegovy. And Wegovy is now marketed for obesity. Next slide. So in conclusions with respect to obesity, prior to metabolic bariatric surgery, obesity was rarely cured or responsive to palliative therapy. Metabolic bariatric surgery provided long-term remission and cure with mitigation of multiple comorbidities and increased life expectancy. And metabolic bariatric surgery was the progenitor of GLP-1 pharmaceutical therapy for obesity. Next slide. Slide, please. So, what's the future for these four progenitors? Partial ileal bypass? Yeah, may have a role still in lowering LDL for patients who are drug refractory. But we have done an interesting study. We've looked at the POSH patients 25 years after POSH and have found that the surgery group developed statistically significantly less type 2 diabetes. So we're now initiating a study in patients referred for refractory hypercholesterolemia, but who also have type 2 diabetes. And if we do a partial ileal bypass, will this cure or mitigate their diabetes? If so, You have an operation one day in a hospital, 1 hour, hour and a half in the operating room, laparoscopically easily done, that may be able to cure both hypercholesterolemia and diabetes. Oophorectomy probably has very limited future. Next slide. And metabolic bariatric surgery, it's going to compete with pharmaceuticals, but I really think its real role will be as an adjuvant, or the pharmaceuticals will be an adjuvant, and it will increase the number of obesity patients that will have surgery and will have drugs, because we'll have a means of doing procedures that are less invasive and supplementing them with drug therapy. And interesting things for the future have come out of this. I put down therapy for traumatic brain injury because that's an area that I and my coworkers are working in. Next slide, please. TBI, or traumatic brain injury, the incidence in the United States is large, but inexact. It's been brought to everyone's attention because of the NFLPA players who very early, in their 50s or so, get TBI, which can progress on to CTE, chronic traumatic encephalopathy, a postmortem diagnosis, and of course, their death. Now, I'm a consultant for the NFLPA, so I became quite interested in this. And a number of years ago, McLennan and a whole group of us published 3 articles in obesity surgery with over 350 references, showing that subjectively and objectively by MRI studies that TBI has a great similarity to obesity. So we thought, well, why don't we take some NFLPA players who are obese, and a lot of them are obese, especially the linemen, when they leave playing, or some of them are obese while they play, but a lot of them get obese afterwards. And they also have TBI. Let's do a sleeve gastrectomy or a gastric bypass and see what happens, not only to their obesity, which we know what will happen, but to their TBI. And we are just starting to initiate that study. Next slide. So, what is the future for these progenitors? I've said for for diabetes, there could be a partial ileal bypass. Perirenal transarterial sympathetic ablation. That's fascinating. There is a fellow by the name of Mahood, who is a researcher in hypertension in Berlin. And he goes up both femoral arteries and heat ablates the sympathetic plexus around both renal pedicles. So he knocks off the sympathetics to the kidneys, and blood pressure goes down. We knew that would happen. But he's also shown that in patients who were type 2 diabetics, they became normalized for at least 3 months. That is certainly metabolic surgery. And for diabetes, it's been advocated gastric and duodenal electrode stimulation, ileal interposition, duodenal blockade, sometimes by stripping the mucosa of the duodenum and then letting it repopulate with newer cells, pancreas transplant. Refractory depression is another interesting story. There were 2 investigators who said, let's stimulate the vagus nerves below the diaphragm. Let's see if people lose weight. And they did. Not much, but they did. They said, well, this is such a simple operation. Let's take one vagus nerve in the neck and put a little collar around it, a little stimulator, and let's see if that does something for obesity. It did nothing. But they noticed, serendipitously, that in their patients who had a history of refractory depression, refractory to psychotherapy, drugs, they got better. Some of them got well. So today we have psychologists, psychiatrists asking us to put these collars on vagus nerves for refractory depression. And of course, we can also do bilateral carotid sign stimulation for hypertension. Next slide. Now, Bill mentioned our implantable infusion pump. Well, that's sort of a metabolic mechanical implantation. In the 1970s, we came up with this pump. We used it for insulin infusion, chemotherapy. It's still being used for chemotherapy, intrathecal therapy for pain control. But our dream was to make a pancreas. And we were told by others that they were just that close to a implantable measurement of glucose levels, a glucose sensor. And we had a little interdigitator, a little micro computer. And so we would have had a pancreas, implantable mechanical pancreas. But they never got the glucose sensor. And this is where it is at. But let us say we could put together a mechanical pancreas. Then by implanting that, we were doing metabolic surgery for a secondary purpose. Next slide. So in conclusion, metabolic surgery has ameliorated and cured certain previously incurable major diseases, the big ones: cardiovascular, atherosclerotic, strokes. Metabolic surgery has increased life expectancy and quality of life. Metabolic surgery has been the progenitor of effective pharmaceutical therapies. And metabolic surgery has improved healthcare and reduced healthcare costs. Next slide. Metabolic surgery is a creator of basic science knowledge. Metabolic surgery is a physical technical exploration of the body's secrets of neurohormonal regulation of the very essence of life. And certainly for us as surgeons or involved with surgery, metabolic surgery is now the fourth discipline to incisional, extirpative, and reparative surgery, metabolic surgery, and I think in the future it may become one of the major disciplines or the major discipline of surgery because the others are fading away. The radiologists are doing the incisional. Extirpative is giving way to group therapy with hormones, etc. Reparative will always be there, but I think metabolic surgery will become a major area in surgery per se. Next slide and final slide. Let us look at the Latin. Etymologic derivations. Metabolic means change. Surgery means hand labor. And therapy means healing. So, metabolic surgery by hand labor is the changer of therapy. Thank you ever so much. It's been a pleasure giving this talk, and I'd be delighted to discuss and answer questions.
Thank you. Thank you, Dr. Buchwald. Thank you.
Yes, thank you very much, Dr. Buchwald. I just want to remind everybody before we get to questions that these webinars are always available on the ASMBS website, and CME and CEUs for tonight's presentation will open tomorrow at 8 a.m. on learn.asmbs.org. CME and CEUs for ASMBS members are free. They are $35 for non-ASMBS members. I don't have any questions just yet in our chat, but I have received several comments and feedback to me personally, messages from my colleagues who are so appreciative of all this information that you just shared with us in this presentation. And you have shed a new light, a new way of looking at metabolic surgery that I think most of us have never really looked at. So I too want to thank you very much. And Bill, I'm sure you might have a question or two knowing you. So thank you very much. And again,
Thank you. Yeah. Thank you, Karen. Thank you.
Yeah, I do have a question. I think it was back, I was reading some of your articles, and back in, that's dangerous, actually. They're very deep. But back in 2010, you mentioned that metabolic surgery was expanded to include the elucidation of metabolic mechanisms for observed metabolic outcomes. Could you expand on that a little bit, in other words?
Well, basically, okay. When people in the past talked of metabolic surgery, what they said, well, that's removing thyroids for hyperthyroidism. Uh, that's a metabolic organ, and you remove it. But that wasn't metabolic surgery. That was extirpative surgery. We removed something that was giving trouble. And so, when Richard Varco and I talked about this, we said there's another way of looking at metabolic surgery, namely something that creates a different metabolic milieu. And so, if you bypass the distal part of the small intestine, 200 centimeters of ileum, cholesterol goes down. So, would you have thought that if you took this nice little ileum that does its absorption and stuff, and you removed it from the circulation, all of a sudden cholesterol goes down, atherosclerotic lesions recede, disappear? That's a metabolic effect. And so then when bariatric surgery sort of was moving along from the 1950s, with a great deal of opposition in the beginning, I think you remember that. I certainly remember it. I was accused at the American College of Surgeons very early of doing psychiatry with a knife, and told if I got mixed up with these fellows in bariatric surgery, I would have no career. And so bariatric surgery, it wasn't even called bariatric surgery, obesity surgery, started as we're going to take care of obesity. And it does. You take people who are obese, 250, 300 pounds, whatever, and they get slimmer. So it does take care of obesity. And then people said, well, now they look better. Well, in our society, we say they look better. There are some societies in the South Pacific where they would say they don't look as good. They like obesity as a form of beauty. So the other thing they said, well, now they can breathe better and they don't have sleep apnea anymore. And now their knees don't hurt as much and they don't need to have their hips replaced. But then other things came to light. These were, and those were anatomical things. But then diabetes went away, blood pressure went down, cholesterol went down, atherosclerotic lesions mitigated. And so that's not an anatomical effect, that's a metabolic effect. So we, pushed to change the term of bariatric surgery per se to metabolic bariatric surgery. And as you mentioned, I was one of the pushers for getting ASBS. When I was president, it was still ASBS to ASMBS. And IFSO didn't want to change its name, but we added metabolic diseases after IFSO and metabolic diseases. So it's taken a long time. Uh, I fought with two of my best friends, Ward Griffin, both deceased at the moment, when he was chair of the Board of Surgery, to put more questions on the board to make it more legitimate. He never did. And then I finally convinced his successor, Wally Ritchie, and they put in a few questions. And it never had any real place in the American College of Surgeons program. And finally, 2 years ago, and again, I was a big pusher on this, we have a named lecture now on metabolic surgery, which I had the pleasure of giving last year. at the American CS meeting. So it's taken a long while, not only for metabolic, let us say, bariatric surgery to be accepted, but for the concept of metabolic bariatric surgery, and then the concept that bariatric surgery is just a subdivision of many, many more wonderful things we can do with metabolic surgery. We just have to learn them. Uh, and so, again, I think the main message that I'd like to leave people with, metabolic surgery is an interesting problem to be solved where we can take putatively normal organs and create metabolic changes that benefit people.
I do have a question here for you. What are your thoughts of fecal transplants from lean patients to obese patients?
I'm sorry, fecal transplants in obese patients?
Fecal transplants from lean patients to obese patients.
Oh, that's been tried. That's been tried. Um, Let me give you some history on that. Originally, this was done in animals. Uh, they uh, they took sibling, I think it was mice or rats, and divided them. And in one group, they fed them a diet where they would get obese. These were animals that had a natural gene for obesity, and the others we restricted their diet and kept them thin. And so then they took the feces, they purged these animals, and they took the thin feces and made a fecal transplant to the animals who were obese, and they got thinner. And so that's a great idea. And I forgot who did this, but somebody took people who were thin and did fecal transplants to people who were obese, purged them, and gave them a new fecal flora, a thin fecal flora, because the flora is different. And that's been shown for a long time between thin and obese people. So now they had uh, a new flora of thin people. They lost weight, but it didn't last. Why? Because unlike mice and rats, we can't keep them isolated. And being out in society, being out in their normal lives and civilization, they soon got back their original flora. So there's something that gives them the flora rather than that the flora gives them the obesity. Um, there was a very interesting sort of parallel study done in Canada where they showed that women who had babies when they were obese had babies that turned into young children who became obese, maybe before the age of puberty. Now, when they studied these women after, I think, gastric bypass, but some bariatric surgery, and they were now no longer obese, but they had more babies. These babies did not become obese. When they grew up, they were not obese. When they were 10, 12 years old, they did not get obese. And so they studied that further. They still carried the gene for obesity. It is a disease, it is a genetic disease. They still carried the gene, but it became glycosylated or deglycosylated. Somehow it was made inactive. So their new kids still had the gene, but it wasn't being active. And so they didn't become obese. So, yes, the fecal transplants can work for a short period of time, but it's not the feces that does it, it's the patient that does it to the feces.
Thank you. I have another comment here. I appreciate this talk, especially your focus on the GLP-1s as an adjuvant to bariatric surgery, as many are now saying that bariatric surgery will be a thing of the past. for those of us who work in the field, we really need to get it out there that treating the complex disease of obesity needs to be a multimodal approach.
I agree with that. I think I've always lacked enthusiasm for anything that seems to be making progress in healthcare and saying, oh, that's bad stuff because it might hurt something that's going on. I mean, that's the fight that we have had. One of the people or group of people that have opposed bariatric surgery have been diabetologists in the beginning because they're taking, we took away their practice. We took away their money because we cured people with diabetes instead of letting them have palliative care for a lifetime, etc. But this has changed. And I think any notable progress is good. And I frankly think the introduction of drugs is going to be good for both drugs and surgery because it's going to increase the number of obese patients who are going to seek therapy. And what are we really doing in obesity therapy? Forget about the other metabolic effects of diabetes and so on. We're trying to reset a set point. Obese people have a set point that's different than non-obese people. I have a son-in-law. I don't know how much this guy can eat. He eats fantastic amounts. I mean, whenever we have a Thanksgiving meal or something, he eats. He has not got 1 ounce of fat. He has a different set point. And we're trying to change a set point, and that's a tough proposition. And the GLP-1, I think, is a helper drug, but it may not be the whole thing either. Because when you do pharmaceutical care, any kind of pharmaceutical care, you try to get a narrow focus. Because if the drug has a big focus, you have what's known as side effects and complications. You try to have a drug that has a singular focus that does its job. Now, bariatric metabolic surgery has a huge shotgun effect. We do a lot of things. We don't understand most of them yet. We know about GLP-1, but we don't understand GIP really goes down, ghrelin goes down, uh, pancreatic hormone goes up. We don't understand most of this stuff yet. Uh, we cut the syncytium of nerves between the esophagus and the anus. There's a submucosal syncytium of nerves, and whatever we do, I mean, gastric bypass, sleeve gastrectomy, scoponoroplasty, we cut those nerves. We reorganize the gut. Something must be happening. And we yet have to explore that, and that knowledge will bring us maybe into other pharmaceuticals and other future. But basically, the metabolic bariatric surgery is like a shotgun. We do a lot of things. Some of them maybe not so good, whereas pharmaceuticals are always very narrow.
Thank you. I don't have anything else right now, Bill, do you?
I was going to follow up on that thought, you might say. Do you think that, basically metabolic surgery will help us sort of elucidate the mechanisms of obesity? In other words, getting down to some of those I mean, it sort of has, you mentioned the shotgun approach though, but in other words, in general, it's kind of like a tool to sort of look at things and effects of things and maybe narrowing some of the surgery, developing new procedures that might, how can you say, get us a little more to sort out some of those BBs that are going out there.
Yes, I agree with that. I mean, the study that I just mentioned, uh, we've always said that there are certain genes that are responsible for obesity. All right. So now we have this study that shows that if you do metabolic surgery, these genes get glycosylated and they're not expressed. That's the genetic terminology. They're not expressed in the newborns, in the children after surgery. Now, that should give us some knowledge. Uh, the idea that we can do things in terms of generating knowledge by surgery has not been a very popular concept. Uh, People have thought uh, knowledge comes from PhDs in the laboratory and maybe internists who are the smart ones. And us stupid surgeons, we're good to do technical things. But going back to 1962, at that time, people really did have a good idea of where cholesterol was absorbed and bile acids were absorbed. Basic physiological stuff, textbook stuff, knowledge stuff. And um, they were doing all sorts of experiments with isotopes at that time, trying to figure this out. Where does it come in from, so on. Now, I did a very simple thing. I bypassed the ileum. I bypassed the jejunum. I switched the ileum with the jejunum. I could do these things because I was a surgeon. And we elucidated where things were absorbed. And we found the absorption sites and we found the mechanisms of absorption. And that made its way into physiology textbooks. And so surgery is a tool for knowledge that's long been neglected. And it's so much easier to bypass the jejunum or make jejunum ileal and turn them around than to have double uh, isotopes and see the relative proportion when you do this and you do that. And that's inexact too. So people have to look upon surgery and surgeons not as technical people totally, but we can contribute to knowledge.
Well, you definitely did that tonight, so thank you very much.
I was just thinking, actually, you mentioned that medicine seems to take a narrow approach, focal. Well, it's interesting when you look at the GLP-1s and now you look at the GIP and the glucagon agonists and mixing them all together in a drug. You're kind of they're sort of taking a card out of the surgeon's handbook, you might say.
Yes, yes, and we have given them the knowledge. I mean, the GLP-1 has been around for a while. I mean, the Gila monsters like to make it, uh, and so it's been around. But to say it does something for diabetes and does something for obesity, that came out of surgery. That came out of metabolic bariatric surgery. And then with that knowledge that the surgical community propagated, the pharmaceutical houses can make their drugs.
Extremely interesting tonight. Thank you so very much. Anybody else, any last minute comments, questions for Dr. Buchwald? Catch him now while you can. We're so lucky to have you tonight. I'm telling you, this is amazing.
Well, it was a pleasure.
Oh,
I'm emeritus now. With COVID, I missed going in to the university, and well, certainly I operated till I was 84, but then I stopped. But basically, to go in and teach, I miss it. Um, I went to the ASMBS last year, of course, and my wife came with me, and we got COVID, and that wasn't fun. Uh, and today, I'm very grateful for Zoom and the ability to sort of do what I like to do. And so I thank you.
Yeah, thank you so much for coming tonight. This was awesome. I know we missed you last at the ASMBS conference, probably because of this whole COVID thing, I'm guessing. But thank you so much for coming tonight. Bill, any last parting words you have, or?
Yeah, I have one thought, mostly for the APPs out there. Something I found that was really helpful is just to explain this to patients, to explain where GLP-1s came from. And it's interesting because, those patients that were, they didn't want surgery, they wanted medicine. But then when they learned that it's come from surgery, from gastric bypass particularly, uh, in other words, it's interesting. Later on, they have a better, a more, broader look at surgery, and because sometimes they may need to go there. And I just as something that helped me, in other words, along the way. But it sort of comes from the work of Henry and all his colleagues, Walter Flores, and uh, just an amazing thing. But thank you.
Oh, you're very welcome. And I think, Walter is a very close friend of mine. Uh, it gives us joy to do what we do. And, I mentioned my old friend Jerry Stamler. He was still getting grants when he was 100 years old. Uh, it's good to do what we do. I've have we got time for a little anecdote?
Sure.
Uh, my office was in the heart hospital, and I had to walk through the janitorial area to get to the operating room, which was in the next building. And so I got to know a lot of the people in the janitorial services, and one in particular, because we were both in Strategic Air Command where we were in the Air Force. And I would go through and I would say, "How are you?" Usual greetings. "How are you? How are you doing?" And I would get an answer, "Oh, it's Monday," or "Thank goodness it's Friday." And they lived from Monday to Friday because they had to earn a living, and they were living for the weekend. And how much time of their lives were they wasting? It is much better to say, "Oh, it's Monday. I have a whole week of joyous work ahead of me," rather than, "If I can just get through the next 5 days, I can go out and golf or swim or whatever." So taking joy in your work is a wonderful thing.
Wow, very profound and something to really think about. And Bill, what your last words? You have a post here that's exactly what I was thinking of taking from this and putting into our practice. So the two of you, thank you very much for your words and your presentation. Truly appreciate it.
Again, it's my pleasure. Thank you for having me.
All right, we'll have to tap into you another time.
Yes.
All right. Thank you, everybody. Have a good night. And again, thank you, Dr. Buchwald and ASMBS for supporting this for us.